Okay. Okay.
नहीं है, आपका नहीं चल रहा ठीक से। Welcome to Mahamana case discussion series. Sorry for the delay. So today's session will begin with our invited talk. Today's talk will be on HPV positive oropharyngeal carcinoma management, and it will be presented by Dr. Natarajan Ramlingam. He is an associate professor, Department of Head and Neck Oncology, CMC Vellore. Welcome, sir. शेयर करने हो रहा है ना?
Hi, can you hear me?
Sir, can you hear me?
Yeah,
Can you
I
make
can.
it a full screen?
Once. Is it okay?
Yes, sir. Thank you.
Please let me know when we can.
Sir, we are not able to hear you.
Can I start now?
Yes, sir.
Yeah. Good evening. I am thankful for sir and Mahamana team for giving me this opportunity. Today we about
Sir, we are not able to hear you. There's a lot of disturbance. There's a break in your voice.
how is it now?
It's still breaking.
1 second. Now how is it?
Sir, I think it's still the same. Some problem with the network?
1 second.
हाँ अच्छा तो रहता ही है सर, लोग वो पता चल जाता है आपको।
Can you hear me now?
Yes, sir, we can hear you.
Okay. Sorry for the delay. I'll be presenting on the evidences for the management of P16 positive oropharyngeal squamous cell carcinoma. So coming to the incidence, as we all know, the incidence is the highest in the West, with attributable fraction of around 30.8% to 42.7% in this recent publication in cancers. Coming to the Asian population, the ASIR is on the lower side with around 0.49 per 1 lakh in males and 0.10 in females. The proportion of oropharyngeal cancers attributed to HPV ranges from around 15 to 20% in India. So why is this HPV positive thing is important in oropharyngeal cancer is that the select population is affected. The incidence is actually rising if you compare with every decades, and it is especially rising in the oropharyngeal cancer group, and this parallels a decline in smoking, which is mainly seen in the West. And all these cancers, without when patient is not a smoker or alcohol intake, there is an improved survival. So how does it differ from tobacco related cancer? These patients tend to be young with no history of addictions, have a lower T stage and a higher N stage, have a poorly differentiated tumor component. Patients tend to be in higher socioeconomic status with oral sexual history. So the survival, as we see in the West, there is an increased better survival beyond 15 years, increased proportion of HPV positive cancers, and the reasons for this increased survival is due to the increased proportion of HPV positive cancers, and also from the reduction in tobacco exposure and better radiation delivery and concurrent chemotherapy. But whereas in the Indian context, we can see in this paper by Vedang Murthy sir that there is no difference in the oral survival or disease-free survival between P16 positive and P16 negative cancer. This can be because of the coexisting smokeless tobacco usage, which is more prevalent in the Indian context. So coming to this landmark paper in NEJM, which was published in 2013 by Kian Ang et al. This was a post-hoc analysis of RTOG0129, where almost 64% of the patients were HPV positive. They found that patients who had early T stage, who were HPV positive and who had lesser smoking in terms of less than 10 pack years had a better survival as compared to the other two cohorts. This was the first recursive partitioning analysis which was done. It showed that there was a subset of patients in the P16 positive cancer group which had significantly better survival than the other cohorts. This was further identified in the study by Brian Sullivan et al., where they found that candidates whose treatment can be de-intensified. They were actually, if you see that HPV positive cancers who had a lesser nodal burden, lesser T stage, and who were non-smokers. So they found out that they divided patients of oropharyngeal cancer into three categories: low risk, moderate, and high risk. Patients who are HPV positive, who smoke less than 10 pack years, who had lesser nodal burden, they constitute the lower risk population. So these individuals can be targeted for de-intensification strategies. So why de-escalation is important? Because these patients tend to have better prognosis and they have more of a non-cancer related death with definitive CTRT around 20 to 30%. They have a better response rate to chemo-RT. Different patterns of relapse, not local. They have late and distant metastasis. These patients have a younger age at diagnosis and lesser incidence of comorbidities and presentation. So what are the de-intensification strategies which can be used? They are the first being the replacing the existing chemotherapy regimen with a biological therapy, either in the neoadjuvant setting or in the concurrent setting. The other types can be reduction in RT dose based and the reduction in dose of RT based on the response to neoadjuvant chemotherapy, change indications of adjuvant RT when surgery is being performed, and giving only RT and lesser invasive surgeries. So we'll be discussing about broadly two things. One is the non-surgical trials, evidences, and the surgical trials. Firstly, coming to the non-surgical ones, I'll be discussing about 4 trials: the RTOG 1016 de-escalate, and TROG 1201, and the Swedish study. So these studies actually randomize patients according to radiation with cisplatin as compared to cetuximab. So coming to the first study, RTOG 1016, this was a phase 3 trial which randomized P16 positive oropharyngeal cancers with the T stage 1, 2, 3, 4 stratified into T stages early and late, N stage N0 and N plus, N2 plus, and smoking less than 10 packets and more than 10 packets. They were randomized to two groups. One is the existing IMRT with cisplatin, which was compared to IMRT with cetuximab. Around 400 patients were randomized into two arms. They found out that after median follow-up of around 4.5 years, the radiotherapy with cetuximab combination did not meet the non-inferiority criteria for overall survival. The hazard was around 1.4. Survival was also lesser in cetuximab group, and progression-free survival and locoregional failure was significantly higher in the cetuximab group. So the risk of death was estimated in the cetuximab group to be increased by 45%, and risk of progression by 72% and failure by 105%. The next trial, which was the de-escalate trial, they had the same type of trial setting, but the main primary endpoint was toxicity comparison, and secondary endpoints were survival and time to recurrence outcomes. The same regimen was used. Around 165 patients were randomized to two arms. What they found is that the recurrence rates locoregional was more in cetuximab, around 12%, and also the distant metastasis rates were also high in 9% in cetuximab arm. And when they looked at the toxicities, they were comparable, but the global QOL outcomes were not significantly different. The third trial is that Swedish trial, ARTSCAN 3. This was a randomized phase 3 trial which compared oncological outcomes and treatment toxicities between radiotherapy with weekly cisplatin versus weekly cetuximab. This was at 3 years. The overall survival was 88% in cisplatin and 78% in cetuximab, which was approaching significance, but a hazard ratio of 1.6. The cumulative incidence of locoregional failure was 23% in cetuximab versus 9% in cisplatin, which was significant. This also, the conclusion was similar to the previous two studies. The fourth trial was from the Trans-Tasman Radiation Oncology Group, where they looked at patients who were stratified and randomized to RT plus cetuximab with as compared to cisplatin. The 3-year failure-free survival rate was 93% in cisplatin as compared to 80%, which was significant. Look at the toxicity profile also. The patients with cetuximab had more of grade 3, 4 adverse effects rate, with risk difference also being plotted. So the implication of all these trials is that cetuximab is not to be substituted for cisplatin in HPV positive oropharyngeal cancers. Cisplatin remains the mainstay. Toxicity remains the same, but this kind of combination with chemotherapy can be explored in future trials. So the next type of de-intensification strategy is to omit the concurrent chemotherapy when giving radiotherapy. This is one trial which is phase 2 trial, NRG-HN002, which was done in HPV positive non-smoking locoregional advanced oropharyngeal cancers. Patients had to have less than 10 packets of smoking. Were randomized to two groups. One is 60-day IMRT with 6 weekly cisplatin, when compared to 60 days of only IMRT. So this was a phase 2 study. The aim was to achieve a 2-year PFS rate superior to a historical control of 85% and 1-year mean composite score of more than or equal to 60 on Madati score. So 306 patients were randomized, and the 2-year PFS rate was 90.5 in the experimental arm, which was more than the aim which was set up initially. And also the Madati score were 85.3 in the concurrent chemotherapy arm as compared to 81.6 in only RT arm. The survival rates were also similar, but only the grade 3-4 toxicities were more in the cisplatin arm. So this, based on this, the phase 3 trial is being planned, wherein to replace only radiotherapy alone as compared to CTRT in select group of patients. The other type of de-intensification is to assess the RT based on the response to chemotherapy. So basically induction chemotherapy followed by different types of radiation regimens. So this is the Optima trial. It's a small trial of 62 patients. Patients were classified as low risk or high risk depending on the type of T stage, N stage, and the amount of smoking. All the patients received 3 cycles of carboplatin, Plaquenil, and they were stratified into 3 types. Patients who had more than 50% response is low risk. They received RT at 50 grays. Low risk patients with 30 to 50% response or high risk with more than 50% response received 45 grays of chemo RT. All other patients were poor responders had the CTRT, which consisted of paclitaxel, hydroxyurea, and full dose of RT. So what they found is that 62 patients were enrolled, of which 28 were low risk and 34 was high risk. Of the low risk, 71% received 50 RT 50 grays, and the 21% received chemo RT of 45. So what they found is that the 2-year PFS and OS were similar. Grade 3 mucositis was very less in patients who received less RT, and that is RT 50 and CT RT 45 grays, and also the PEG-2 dependence were significantly lower. So this showed that based on induction chemotherapy, the response of induction chemotherapy response, the dose of radiation can be changed. The other study which we have looking at is that E1308 is a phase 2 study where similar patients were given induction chemotherapy of cisplatin, paclitaxel, and cetuximab. Based on the response, which means 2 types, clinically complete response, they were given only low dose IMRT of 54 grays plus cetuximab weekly, and the other had full dose IMRT plus cetuximab weekly. For responders with the conclusion was that for induction chemo responders, reduced dose IMRT was had a good results, which was worthy of further study. So the radiation and dose reduction resulted in significantly improved swallowing and nutritional status. So coming to the surgical part, TORS was approved by FDA in 2009. The advantages is that it avoids a pharyngotomy or mandibulotomy or a midline lip split. And there are 7 degrees of freedom with good stabilized instrumentation, tremor reduction, and ability to operate without line of sight restrictions. And patients had better tumor removal in terms of on-block removal, and clinicians had a shorter learning curve with better 3D visualization. So these are the indications and contraindications which we all know mostly. I'll move on. So the trials which we looked at, I divided in the surgical trials into 2. One is surgical versus non-surgical trials, and the other was surgical with de-intensified adjuvant treatment. So first we'll be looking at the surgical trials, Orator and EORTC 1420. Both are similar inclusion criteria. EORTC is ongoing, so I will not be talking about it. I'll be talking about Orator trial. This was a multi-center phase 2 RCT, which included T1, T2, and N0 to N2 oropharyngeal cancers. The primary endpoint of assessment was a swallowing-related QOL at 1 year using the Matadi inventory. 34 patients were there randomized in both arms. You can see that the survival is similar for both treatment arms, but when they were stratified as P16 positive and P16 negative, the P16 negative had poorer survival. So coming to the QOL Matadi inventory scores, at 1 year, all the total score was around 86.9 in RT group, whereas it was in the 80.1. So significantly different, but this study had a 10-point difference, which was predetermined. So it was didn't achieve the aim, but it was significantly different. So the patients treated with radiotherapy showed a superior swallowing-related QOL scores 1 year after treatment. The downside of this trial was that the lesser number of sample size and patients were having many patients had tracheostomy, which significantly impair the scoring system. So coming to the long-term results of the same trial at 45 months, they found that the swallowing QOL differences between the 2 groups were persisting but decreasing over time. So this showed that long-term, when we look at the 2 types of treatment, the swallowing QOL, there was some difference, but it was actually the scores were looking similar for both the treatment groups. So the conclusion was that patients with oropharyngeal cancer should be informed about the pros and cons of both treatment options and then offered based on their discussion, the treatment type can be offered. So what are the lessons learned from this orator trial is that though there was no differences between the survival types and also the swallowing related outcomes, clinically meaningful differences were not seen, but there were some patients who had some subtypes of patients who had better differences in treatment. One was the patients with palatine tonsil cancers and also the base of tongue tumors. So base of tongue tumors, the differences in swallowing function was between the treatment analysis was mainly seen in this subset of tumors. And also patients with nodal involvement had a better scores in the RT group. So these type of subset of patients can be further studied in future trials to look at better application of this radiation and TORS. Coming to the other studies where de-escalation of adjuvant treatment were done, I'll be talking about 4 or 5 trials which were some 4 or 5 trials which results have been published. The first is the E3311 trial where all the patients who had underwent transoral resection with neck dissection, they were randomized into 4 arms based on the pathological features. The arm A patients who had negative margins N0, N1, no NE were randomized to arm A, which was observation. They were deemed low risk. The second subset of patients who had close margins less than 3 millimeter, 2 to 4 nodes, and less than 1 millimeter ENE without PNA or LVI, they were randomized into 2. One arm B was who received adjuvant RT of 50 grays. The arm C was IMRT of 60 grays. And rest all patients who had positive margins more than 1 millimeter ENE or more than 5 nodes were randomized to arm D, who received full dose of IMRT with cisplatin weekly. So around 38 patients were there in arm A and 100 patients in around 100 patients in the rest of the 3 arms. So the results was that the 2-year PFS and sites of recurrence were almost similar in all the arms. The important thing to note is that in the intermediate risk group, arm B demonstrated higher 2-year PFS progression-free survival similar to standard of care of 60 grays, and toxicities were only 4% in arm B. So based on this study, this ECOG group has planned a phase 3 trial which is comparing transoral surgery plus 50 grays versus the standard of care of primary CTRT at 70 grays. The next trial is the SIRS trial. This is a single arm 54 patients who were after TORS, they were randomized to 3 groups. One was group 1 who had a favorable prognostic features like T1, T2 tumors, N1, N2B, no ENE. They were given observation. And group 2 had intermediate prognostic factors who received 50 gray of RT, and group 3 had 56 gray of chemo RT. The results were also similar. There was no difference in CS from surgery to recurrence, but the number of adverse effects events were more in the third group, and also the disease-specific survival also comparable. The other trial is that AWARD trial. In this, the patients who had underwent surgery, patients who had indications for RT for the neck factors. So that means the primary factors had negative surgical margins and no PNA or LVA. These patients were given radiation only to the neck. The primary site was treated as an avoidance structure. So what they found is that at 2.4 years of median follow-up, only one patient had a recurrence at the primary site and one patient had a regional neck recurrence. And the loco-regional recurrence-free survival was around 97.9%. The feeding tube dependencies were 0% at the last follow-up. The other trial which looked at de-escalation in the adjuvant setting was ADEPT trial, which looked at the role of chemotherapy in patients with extranodal extension who had been treated surgically. The endpoint was DFS and LRS, loco-regional control. All patients were treated with transoral surgery and neck dissection. Those patients who had negative margins at primary site but with ENE were included in the study and treated with RT alone or with CTRT with cisplatin. The problem was that there was slow accrual and funding issues. Only 42 patients were included. The results have not been published till now. So this group of this type of ENE positive patients can be studied more. The other trial is the Orator 2 trial, which was started as a phase 3 RCT, which compared primary RT with surgery plus adjuvant RT with 50 grays. The problem with the study was that 140 patients were planned to be accrued, but it was terminated after 2 treatment-related deaths in the surgical arm, which was mainly due to oropharyngeal bleeding and second due to cervical spine osteomyelitis following RT. So this trial was ended prematurely, which was the reason being that the surgical arm had unacceptable grade 5 toxicity. This is one trial which is ongoing, Pathos trial in UK, where the reduced adjuvant intensity of was planned into 3 groups. One is group A, which no adverse features, group B with intermediate risk, and group C with high risk. So it has a complex randomization pattern with almost 5 arms. Arm B1, which is control arm, which is post-operative RT with 60 grays, test arm with post-operative RT of 50 grays, and arm C1, which are CTRT with 60 grays and the fourth arm will be post-operative RT alone. So this trials is study is ongoing. Results are expected by 2026. So summarizing the trials, substitution for chemotherapy was de-escalate trial RTOG 1016 and TROG, which is trans-Strassman group. Reducing radiotherapy dose is ECOG 1308 and in the primary setting and the Optima trial. Post-surgical setting ECOG 3311. Substituting surgery for radiotherapy is the best of trial. I have not talked about because it's ongoing. And the last one is the Pathos trial and NRG HN002. So coming to the NCCN guidelines, as per the latest version, patients with early stage T1, T2, N0, P16 positive can be offered two types of treatment modality. One is definitive RT and the other is surgery with bilateral or selective neck dissection. Patients with no adverse features can be followed up. Patients with adverse features can be treated with either CTRT or re-resection in case of positive margins and other risk factors with RT or CTRT. The evidence for this comes from the other for the oral cancers, the adverse RTOG study and the EORTC study by Bernier and Cooper. So that's why the category recommendation is 2B. Because those studies didn't have HPV status, which is being mentioned in the study group population. The second subset of patients is the T0, T2 with one single node, which is less than 3 centimeter. The 3 types of treatment can be offered, which is surgery with neck dissection or definitive RT or CTRT. Patients who had other risk factors like external extension and positive margins received CTRT. Positive margins had either re-resection or CTRT. Other risk factors, which were like the same criteria which was seen, which I presented in ECOG 3311, those patients can have a de-escalated adjuvant treatment of 50 grays. That was a category 2B recommendation. The third group of patients are early T stage, but end stage, which was single node, which is more than centimeter or multiple nodes. The same type of CTRT or resection can be offered. In addition to that, the category 3 recommendation of induction chemotherapy followed by RT or CTRT has been recommended. The fourth group of patients is high T stage tumors. Their preferred treatment was CTRT, which is being in the NCCN guidelines. So concluding, HPV positive oropharyngeal cancers have a unique opportunity of de-escalation. De-escalation strategies should be undertaken with caution and under clinical trial setting as per ASCO guidelines. And cisplatin is the mainstay. De-escalation of RT dose can be considered in the adjuvant setting, and TORS and IMRT are both valid options for HPV positive cancers. Thank you.
Thank you, sir, for the informative talk on the evidence-based management of oropharyngeal CA.
Thank you.
And I would also request you to join our panel of examiners in our upcoming case presentation.
Sure. Thank you.
So today our case presentation will be done by Dr. Prakash Suta. He is he's a MCH resident from BBCI Guwahati, and he'll be presenting a case on oropharyngeal carcinoma. And our examiners for today are Dr. Monali Swain. She is a professor, Department of Radiation Oncology, TMH Mumbai. Dr. Akshat Malik. He is a senior consultant head and neck surgeon from Max Super Speciality Hospital, Saket. And Dr. Satakshi Chatterjee. She is a consultant head and neck surgeon from Apollo Cancer Center, Mumbai. Welcome, everyone. And Dr. Prakash, you can start the case
Good
presentation.
evening, everybody. I'm Dr. Prakash from BBCI Hospital, Guwahati. Am I audible to you, ma'am?
Yes, you're audible. Could you please make it a full screen? Dr. Prakash?
Good evening, respected teachers. Am I audible? Dr. Prakash here.
Yes, you're audible.
Should I proceed, ma'am?
Yes, you can proceed. Can you hear me?
Yes, ma'am.
Yeah, please proceed.
My screen is visible, ma'am, right?
Yes, yes.
Okay. So I'll be presenting a case on oropharyngeal carcinoma. So there was a 42 years old male who's hailing from Dhubri, Assam, labor by occupation, and he presented with chief complaints of right side neck swelling since 4 months, and complaint of foreign body sensation throat since 2 months, and complaint of earache since 2 months. The patient was apparently asymptomatic 4 months back when he noticed small swelling over the right side of neck, which was approximately the size of a grape initially, which gradually progressed to the present size. And this was associated with the right ear ache, which is dull aching, non-radiating, episodic, and relieved with medications, and not associated with any hearing loss or ear discharge. The patient didn't have any history of difficulty in swallowing, any voice change, breathing difficulty. There was no history of fever, cough, weight loss, night sweats, no history of any epistaxis, nasal obstruction, or nasal twang, and no features suggestive of aspiration, nasal regurgitation, and no history of chest pain, breathing difficulty, or bone pain. There was no significant past history, not a known case of diabetes mellitus, hypertension, or any other comorbidities. This personal history, he smoked 10 BDs per day since last 12 years, and also chews betel nut daily since last 12 years, and is an occasional quid user. His sleep appetite, bladder habits are normal. There's no drug allergy, no history of high-risk sexual behavior. There's no significant family history. The general examination, patient was conscious, oriented in time, place, person. Performance status 0. No pallor, icterus, cyanosis, lymphadenopathy, or edema. Vitals normal. And the rest of the general examination was normal. Coming to local examination, oral cavity examination, mouth opening was normal.
Can you just summarize the main complaints of the patient once before proceeding with the examination?
Yes, sir.
Within a line
Yes.
or two.
So the summary of the patient is, he was a 42 years old male, sir, who was hailing from Dhubri, Assam. And he presented with chief complaints of right side neck swelling since 4 months, associated with a foreign body sensation since 2 months, and earache since 2 months. He is a
Ear pain in such patients.
Sorry, sir.
What are the causes of ear pain in such patients?
So if a patient is presenting with a foreign body sensation and a neck swelling, and the patient having a earache, this might be because of a referred otalgia in such cases. If Referred otalgia can be the cause if this patient is having any sort of primary in the aerodigestive tract, sir.
Can you tell about like various locations where the tumor can be and how it will be referred to the ear?
Yes, sir. So the referred otalgia can be from various sites in the aerodigestive tract. Like if it is in the hypopharynx, larynx, so in that case, it is referred via the vagal nerve, sir. So and if the lesion is in the tonsil, base of tongue, oropharynx region, it is referred via the glossopharyngeal nerve. And if it is in the oral cavity, anterior two-third tongue, it is referred by the lingual nerve, sir. So should I tell the pathway, sir?
No, that's fine. Also, where the pain is located with regards to ear, whether it's anterior or deep, that
Yes.
also varies according to which
Yes.
pathway we are talking about.
Absolutely. So for glossopharyngeal nerve, it's an oropharyngeal nerve involvement. So it's referred via the Jacobson's nerve. So it usually supplies the tympanic plexus and the tympanic membrane in the middle ear. So it's a deep-seated pain. And the anterior pain will be mostly the auriculotemporal nerve, which is a referred pathway again via the lingual nerve, which is shared via the lingual nerve. So it comes from the anterior part of the oral cavity, anterior two-thirds, floor of mouth, that pain. So. And hypopharyngeal pain is usually referred in the posterior part of the, like in the mastoid region or the posterior EAC regions because of the the vagus nerve.
Sure. Okay. Kindly proceed with your examination findings.
Yes, sir. So the local examination for this patient, the patient.
Dr. Prakash, sorry to interrupt. I'm just willing to mention that it might not be a good idea to write no lymphadenopathy because you have just mentioned that the patient presented with lymph nodes in neck or maybe
Yes,
a mass in neck.
yes,
Trivial
ma'am.
point, but
Yes,
you
ma'am.
know,
Right.
in exam they may catch you on this.
Absolutely, ma'am. Ma'am, should I proceed with local examination?
Yes, please.
So the patient oral cavity, his mouth opening was normal, tongue movements were normal, and the rest of the subsides of the oral cavity were normal. Coming to oropharyngeal examination, on inspection, this patient had a proliferative growth, which was measuring 2 into 1 centimeter, involving the right side tonsil, limited to the tonsillar bed. Anterior and the posterior tonsillar pillars appeared free. The tonsillolingual sulcus, the posterior two-third tongue, posterior pharyngeal wall, and the visualized soft palate was free. On palpation, the inspectory findings were confirmed. The growth was 2 into 1 centimeter, limited to the tonsillar fossa on the right side, not extending beyond the anterior or posterior tonsillar pillars, and induration was limited to the growth and did not bleed on touch. The tonsillolingual sulcus was free and the base of the tongue appeared free on palpation. Then we did an examination under anesthesia for this patient, which confirmed the findings. The growth was involving the right side tonsil, limited to the tonsillar fossa, but it was more towards the lower pole of the right tonsil and slightly extending into the lateral pharyngeal wall. But the pillars were free, tonsillolingual sulcus were free, the vallicular base of tongue, epiglottis was free, and the rest of the findings were normal, ma'am.
Go
Coming
ahead.
to, yes, ma'am. So coming to neck examination, on inspection, there was a swelling visualized in the right level 2 region, which measured 3 into 2 centimeter, ovoid in shape, well-defined, smooth surface, non-pulsatile, skin above the swelling is normal. On palpation, the inspectory findings were confirmed. It was the right side level 2, 3 into 2 centimeter nodal swelling, ovoid shape, well-defined, smooth surface, firm in consistency, non-tender, no local rise of temperature, skin above the swelling is normal and mobile in both horizontal and vertical direction. So my summary is like a 32 years old male with a 4 months history of right side neck swelling and foreign body sensation throat, with history of smoking and betel nut chewing, presents with growth over the right side tonsil and right side cervical nodal mass. So the provisional diagnosis based on the clinical history and examination is growth in the right side tonsil, likely malignant with the cervical nodal mass, ma'am.
All right. So how will you investigate this patient?
So my management for this patient will be first we'll do an first, since we have seen the growth, so we are going to do a punch biopsy or a biopsy of the lesion from the oropharynx, that is the right tonsil, and after biopsy we will also do an imaging for this patient since it's a tonsillar growth. So we'll prefer to do a MRI imaging for this patient, sir, to look for the extent of the tumor growth.
Dr. Prakash, so is it only MRI you would like to do, or you want to add a CT scan to this, or MRI is enough? And what are the investigations would you like to do for a distant metastasis?
Ma'am, in this case, ma'am, I feel MRI and CT scan can be used as can be complementary to each other if we want to see for the bony involvement. But in this case, since it's a soft, it appears to be limited to the right side tonsil. So MRI would give adequate information regarding the extent of the tumor, involvement of the adjoining structures, whether any neural involvement is there, whether extension into the and also about the cervical nodal metastasis, it can give an idea. And about the distant metastasis, ma'am, a PET scan will be ideal for a distant to know the distant metastasis, ma'am.
For this T1 and N1 disease, would you want to do PET-CT or anything else would be suffice? And another question is, you have done the biopsy. Would you like to do anything else on the biopsy sample?
Yes, ma'am. Regarding the first question, ma'am, like as this case looks like a N1 and a T1 N1 disease. So in this case, like a PET-CT scan is ideally not advisable. PET-CT scan is usually advised if we have a larger nodal mass, or if there's a lower nodal level like a level 4, or if you're suspecting a midline tumor which is going to give bilateral metastasis, or in cases where there's MUO, we can go for a PET-CT scan. But in this case, we can even do for CT thorax and abdomen, or USG abdomen might suffice, ma'am. And coming to the other question of biopsy, yes, ma'am, since it's a oropharyngeal growth, so I like to send the tumor for immunohistochemistry for P16, ma'am, to look for the P16 status of this patient, ma'am.
Dr. Prakash, I just wanted to ask you something. You mentioned that this patient, you have done an evaluation under anesthesia, right?
Yes, ma'am.
So when a patient is presenting to you with a neck mass, clinically, you are having a suspicion of a disease. Clinically, were you able to see in the oropharynx there is a tonsillar growth?
Yes, ma'am. I saw this patient. So
Because
clinically,
yeah.
yes, ma'am.
So
So
your sequence of investigations, what you are saying is correct. All the things that you are saying that MRI could be done, PET could be done. But your sequence of investigations, can you please elaborate us a little bit more? What would be your sequence of investigations for somebody presenting with a neck mass, and when you are clinically suspecting there is an oropharyngeal lesion which is visible to you?
Yes, ma'am. So when such patient comes to the OPD, we'll first do the clinical examination. And after that, on clinical examination, I'm finding a oropharyngeal tonsillar growth and a neck mass. So for the oropharynx, for this patient, the next step will be to do ma'am, an endoscopic examination and to evaluate the endoscopic examination. We usually do a DL-scopy biopsy, direct laryngoscopy and biopsy of the mass. And if we are able to take the mass, like the biopsy, and after that, ma'am, we'll...
No, just a second. A direct laryngoscopy biopsy will require you to put the patient under general anesthesia, right?
Yes, ma'am. So that is one option, ma'am.
Routinely, would you advise? You mentioned that clinically you were able to see a growth in the oropharynx, in the tonsil at the clinic. You can also see a mass in the neck. So do you really recommend in such patient DL-scopy? It's an addition, it's not wrong. But is it required for all the cases? What will be your sequence of investigations is all I'm asking.
Can you do something as an office procedure? That is what Dr. Satakshi is wanting to ask.
Yes, ma'am. If the growth is quite exophytic, so we can do under local anesthesia, we can do a punch biopsy as an office procedure also, and we can send the tissue for analysis, ma'am.
Correct. And what about if you feel that what you would like to avoid it for bleeding risk, right? If
Yes,
you feel
ma'am.
that Yeah, what about the neck node? Can you
Uh,
procure tissue from there as well?
Ma'am, we can also do an FNAC for the neck node, but the thing is, ma'am, if we are seeing a growth in the oropharynx, the biopsy from there will ideally suffice, ma'am, in this case.
No, suffice, I agree, but is it required is all I'm asking, to do a DL scopy under general anesthesia for obtaining tissue?
No, ma'am, we can even do an office procedure in this patient. So office procedure will lead to will give us a biopsy from the oropharynx, and we don't have to do a FNAC from the neck node, ma'am. Since we are
Okay,
seeing,
if you're doing a FOL and biopsy, are there any specific indications where you probably need to do a DL scopy or examination under GA?
yes, sir.
Generally,
If
like FOL will suffice, right? So
yes,
are
sir.
there any specific place indications or scenarios where you would want to do it under GA?
Yes, sir. If there is a growth in the tonsillolingual sulcus area or in the vallicular area, which will be then in those cases where there is more risk of aspirations, we will like to do under GA, DL scopy biopsy under GA, ma'am.
And base of tongue, right?
Base of tongue lesions, yes, ma'am. They're more likely to bleed and the patient might have aspiration. So we like to do the general anesthesia.
That doesn't really hold true. You majority of these lesions you can easily tackle through FOL biopsy.
Right, sir. Yes, sir.
If you're considering any patient as a surgical candidate for TORS, probably
Okay,
then
sir.
just to reconfirm the induration or your clinical findings, probably you may want to consider examination under general anesthesia. Also,
Yes, sir.
sometimes submucosal disease may be present. Then again, this may be required.
Okay,
Third
sir.
thing, FOL biopsy, generally the jaws of the biopsy forceps are smaller. All right. So
Yes, sir.
if submucosal disease, then again, you may not get a deep or representative biopsy. So you may want to take a deeper biopsy where you would want to do it under GA rather than a FOL where you will get a superficial, just a mucosa in it, which may not be representative. All right.
Yes, sir. Got it, sir. So, sir, after the biopsy, I'll send the tissue for immunohistochemistry for P16. And after that, sir, I'll also send the patient for imaging, like an MRI, sir, in this case.
Right. So say this was a very small lesion, 1 into 1 centimeter restricted to tonsil itself.
Yes, sir.
You would prefer doing a biopsy first then, or you would prefer doing an MRI first?
So in this, like if the lesion is small, so we should ideally go for MRI imaging first, so that the biopsy leading to edema won't hamper, or it might upstage the report on imaging, sir. So if it's a small lesion in the oropharynx, we can, or even like in any part, we prefer to do imaging first, followed by biopsy. But this growth looked quite exophytic, so we went ahead with biopsy first, followed by imaging.
Okay. Okay. All right. You're talking about aspiration otherwise. Say this was a more extensive lesion.
Yes, sir.
Would you, how would you assess the swallowing in the patient then?
So we can assess the swallowing in this patient by doing a FEES examination, sir. Functional endoscopic evaluation of swallowing, and we can get a PAS penetration aspiration score, and we can comment about the aspiration of if the score is more than 6, so we can say the patient has obvious aspirations.
Okay. But even penetration is significant at times. Also, you need to be aware of residue, pharyngeal residue. So there is a bulky lesion in pharynx. So patient may have some valvular residue. Sometimes the mobility of the pharynx or larynx per se itself may also be restricted. There might be some pyriform fossa residue. And then over a period of time, these may move out, right?
Yes,
What
sir.
are the other ways you can check for swallowing in these patients?
We can also do a 100 ml water swallow test, sir.
Yeah, so that's the simplest thing which you can do in OPD.
Yes, sir.
How do you do that?
In that case, so we ask the patient to swallow water, and we see if the patient coughs like 100 ml, with gulps. And we see the cough after having liquid, sir.
Yeah, so you ask the patient to take 100 ml, that's about a cup of water, half a cup of water. And then you need to see in whether they're able to take it without coughing. And number two, how many secondary swallows are required. All right.
Yes. Okay, sir. Got it.
Dr. Prakash, I want to come back to your HPV testing. You
Yes,
said
ma'am.
you're doing P16. What is the gold standard for testing HPV status?
The gold standard to test the HPV status is to look for E6, E7 via mRNA reverse transcriptase, PCR, ma'am. So that is the gold standard.
Very good. So in P16 positive, would you want to go ahead with the HPV testing, or P16 should be sufficient? And what should be the, to say it as a P16 positive, what is the criteria?
Criteria to call it a P16 positive
Yeah.
carcinoma is that on staining, ma'am, it should be more than 70% of the cells should stain, ma'am.
Like what should be the staining? It is a mild, moderate, or like what kind of staining, and it should be only nuclear, or what it should
Is it
be?
standardized, Dr. Prakash? The 70%, is it standardized all across?
I'm sorry, ma'am, actually, I'm not aware of that, but
Sorry, Dr. Monali asked you a question. You may go ahead and answer that.
ma'am, regarding, yeah. So if the P6, ma'am, if the P16 positivity, if the P16 is positive, so it is more sensitive and it is more sensitive test. But if P16 is negative, we can go ahead with HPV DNA in fish, ma'am, in situ hybridization. And that will be more specific. So if P16 negative, we can go for HPV DNA. That will be more specific. And the gold standard is obviously RT-PCR, ma'am. So we can, like, if P16 is negative, we can actually go ahead with HPV DNA also, ma'am.
When it is negative, then you will go ahead with HPV DNA?
Ma'am, ideally, like if you go, like that's the more specific test for this one, ma'am. Like there's it's a like more specific test.
Madam is asking you, if it is negative, will you ask for HPV DNA or you will say that's it?
Actually, in our institute, what we follow is P16 negative. We call it P16 negative tumors, and we don't go ahead with HPV DNA.
Okay, that's correct. Yeah.
So in clinical practice, basically what is being done is what they are asking. So the question around that, if you understood it correct, was we all know that there is a discordant group of patients, right? Where the HPV status may be different in P16 and in the HPV DNA. Simply put, in Indian context, does it matter? Do you routinely ask for both the tests? You
No, ma'am, in
really
Indian,
want to screen out those group of patients?
so ma'am, in Indian context, P16 will be sufficient test. So usually at the institute also we follow the same P16 test is done, ma'am. That is what screens the patient as P16 positive or P16 negative, ma'am.
Why in Indian context this does not matter much? Any idea?
As compared to the Western population, in our Indian continent, ma'am, the HPV positivity rate is.
No, I'm not talking about that. I'm asking this P16 discordant status, what Dr. Monali was asking, Dr. Akshat was asking you. In India, why we really do not stress upon all that routinely? Any comments on that? Briefly, this point was just touched in the talk before your presentation.
I'll sort of rephrase this question for you.
Yes, ma'am. Yes, sir.
That was a P16 positive patient. All right.
Yes, sir.
Will his prognosis be as good as a P16 positive patient in Western country without tobacco usage?
P16 positive patients with tobacco usage do not have that, like the prognosis is not that good, sir. And
are you aware of any studies regarding this? On what basis are you saying this?
Yes, there was a study, RTOG 0129, sir. So in that study, they had mentioned the determinants of prognosis. So in that they had mentioned ki, like smoking, like HPV positivity is good prognosis, but smoking, the prognosis is not good.
Hello?
And HPV positive tumors. Hello. Yes, ma'am.
Yes,
Can
so
you
they
hear
were
me?
the intermediate risk category,
Yes.
that even though
Yes.
they were positive, but they were not as good as P16 without tobacco usage, right? So majority of our patients are tobacco users. So
Yes,
that is
sir.
what both Dr. Monali as well as Dr. Satakshi were trying to ask you.
Okay, sir.
Dr. Prakash, suppose this patient comes out to be HPV positive. Would
Yes,
you
ma'am.
think of changing any imaging modality compared to HPV negative? Like this same stage, suppose it is a P16 HPV positive versus HPV negative. Any thought process on any change of imaging modality for distant metastasis, and why?
So, ma'am, like if we consider HPV positive and HPV negative tumors, in HPV positive tumors, the distant metastasis is is more as compared to HPV negative. So we can like consider doing imaging for distant metastasis. We can even go ahead with PET scan, ma'am, in these cases.
Okay. Actually, this is a very unusual sites of mets can happen with HPV positive tumors.
Okay, ma'am.
Achha, earlier there were questions about discordance between HPV DNA and P16.
Yes, sir.
Are you aware of any studies where they've shown that the prognosis of such patients can vary, and how does it vary? Are you aware of any such thing?
Actually, sir, the correlation was mentioned in RTOG 0129. They mentioned that there was a good correlation between the two. So they mentioned that in P16 positive tumors, the HPV
Are you
DNA.
aware of any newer studies where they are saying that you need to evaluate HPV DNA also?
Not aware.
Sorry, I could not hear you. Hello.
So no, sir, I'm not aware of it. I'll read about it, sir.
So recently, Dr. Mahamana has published in NEJM where he has mentioned that these patients can be divided into P16 positive and HPV DNA positive or HPV DNA negative. They say even if HPV is negative, but patient is having P16 positive, that means the pathway is through E6, E7 mutation, right? So
Yes,
they may
sir.
still have a good prognosis. So they have tried to classify based on HPV as well as P16. Okay.
Okay, sir. Okay.
Dr. Prakash, sorry, I just got logged out because of some technical issues, but I could hear what Akshat was telling correctly. Absolutely, that's the evidence. But, essentially in India, why we really do not bother about that, and maybe if anybody asks you in exam, that should be the reason, is two. One is, as you rightly said, that in India, that percentage of patients of HPV positivity is very less. And
Yes, ma'am.
secondly, when people smoke or use smokeless tobacco, then P16 hypomethylation happens. That's a technical thing. Simply put, that P16 as a marker becomes lesser sensitive, if we put it simply.
Okay.
So for those patients, we specifically do not ask for a DNA test because right now it does not have any treatment implications
Yes,
to
ma'am.
screen that small group of patients. If I had not missed majority of the discussion in between because I got logged out.
Okay, ma'am.
Okay, so I think you discussed about how you would like to investigate the patient with MRI or PET. Just maybe a few questions and then we'll proceed on the management. So you have already clinically understood this is likely a tonsillar malignancy. You have already done a tissue, you have understood. Now, since you are substantiating that you want to do the imaging later after the inflammation, everything settles. Will your choice of investigation matter in any way by whatever you have planned as the treatment or probable treatment?
Yes, ma'am. Actually, imaging, it will help me to stage the tumor, ma'am. The imaging will help me to stage the tumor so that I can
Yes.
prognosticate the treatment plan, ma'am.
Yes, that's correct. You can do MRI, you can do PET-CT scan. All of them are viable modes. What I'm asking is, you have a relatively smaller primary in
Yes,
tonsil.
ma'am.
You have a neck node, which is of around 3 centimeter size, you said, right?
Yes, ma'am.
So your probable line of, it's an oropharyngeal malignancy. You got your P16 status maybe a little later also, but you are planning your line of management. Your investigation will depend on anyway on that, or you will routinely ask as an institutional protocol anything?
I think, ma'am, we'll go ahead with MRI, ma'am. That is what is like routinely done and ideal in this case, ma'am. That is what I feel, ma'am.
Correct. So let's go to the management bit and then we will discuss a little bit more on that. So we have discussed how you'll investigate the patient. Now, what is your plan of management? How will you counsel this patient?
So, ma'am, this patient, ma'am, if it comes, like if the report comes as HPV P16 positive, ma'am, so this case will be T1N1, ma'am, according to the staging of HPV positive. So in that case, ma'am, it will be a T1N1 tumor. So we can give treatment options to the patients. So in T1N1, the treatment options that we have is we can go for first option is we can go for surgery followed by adjuvant treatment. Second option, we can go for chemoradiation therapy in this patient, or we can even enroll the patient in clinical trials. So, ma'am, this is the way I can counsel the patient regarding the treatment plan, ma'am.
Okay, we'll come to the clinical trials bit maybe later, but when you are, say, counseling the patient for surgery or for CTRT, what are your points that you are going to discuss with the patient that, look, this is your benefit if you undergo surgery, this is your benefit if you undergo CTRT,
Yes,
and
ma'am.
vice versa?
Yes, ma'am. So I'll counsel the patient about surgical plan first, ma'am. So I'll tell the patient that there are some prerequisites for surgery. If you're going for surgery, so based on the post-op HPE report, we'll be taking out the primary and we'll be doing the elective neck dissection. In this case, a therapeutic neck dissection also. And based on the post-op HPE report, we might have to give adjuvant treatment to the patient, ma'am, which will be either RT or CTRT, ma'am. And if the patient chooses for concurrent chemoradiation therapy, then the patient will get the treatment at both the sites. And if there is any residual disease, the patient might have to go for any salvage neck surgery, ma'am.
How would you, Dr. Prakash, you are a surgeon, how are you going to convince the patient for surgery? What are the plus points you are going to say, and what are the disadvantages you are going to say about concurrent chemoradiation? And
Yes.
if there is any evidence to show that, okay, this one is better than that, or it is similar?
Ma'am, I'm going to, yes, ma'am, like in favor of surgery, like after we surgically treat the patient, we'll have the post-op HP report, and we can stage the tumor. Post-surgery, we can stage the tumor, and we can also prognosticate better. And with RT and with CTRT, there are side effects of CTRT also. I'll also explain the side effects of the surgery, the risk and complications associated with surgery, which include intraoperative bleeding. There might be post-op dysphagia, maybe there might be difficulty in swallowing. And when it comes to radiation and chemotherapy, there might be acute and late complications of radiation and chemotherapy, like mucositis, xerostomia. There might be a risk of dysphagia, and also skin changes, ma'am. So all these points I'm going to put to the patient.
Okay.
So in this case, ma'am, like T1N1 case, so there are trials which have shown that the overall survival and the progression-free for survival is similar between both the arms in this case, ma'am. In the case of T1N1, so I'll explain that to the patient and also give the pros and cons of each management line, ma'am.
Okay. Okay.
Yes,
So
ma'am.
supposing this patient chooses to undergo surgery as an option, is trying to explore surgery as an option. You
Yes, ma'am.
said that you will do an evaluation under anesthesia. What Akshat was also telling, that to assess the candidacy as well, right?
Yes, ma'am. Yes, ma'am, to assess the candidacy, right?
But before you do that, will you explain to the patient that what is the likelihood that you will land up with trimodality therapy and what can be the outcome of it? Vis-a-vis, suppose your patient stays in a remote area and is not too keen or not too expected to do a good follow-up.
Yes, ma'am.
How will your counseling be like after CTRT? How the patient should be on follow-up? These are two separate questions, but when you are counseling the treatment options to the patient, how will you address these two areas?
Yes, ma'am. Like I'll explain the patient about the post-operative. Like if the patient chooses surgery, so I'll explain the patient about the post-operative follow-up with the histopathological report and the adjuvant treatment needed, and it will include RT and CT both, or maybe RT alone. And
What will be the likelihood of ending up in that scenario in this patient? It's a positive neck, of course.
Yes, ma'am. Actually, like most of the patients do need adjuvant RT, ma'am, in surgical group, ma'am. It has been
So
seen
the
in.
patient will require trimodality therapy in all probabilities, right?
Yes, ma'am.
So I would actually differ in that, Satakshi. But yeah, dual modality definitely, trimodality will be plus minus.
Yes, ma'am. Yes,
Yeah, yeah.
No,
So
I did not follow in here. For example, if you subject this patient to surgery,
yes, ma'am.
and this patient has a positive neck, you know that there is a neck nodal mass. Post-surgery, there is a high likelihood that this patient will receive adjuvant therapy, right?
Yes, ma'am.
it may be RT or CTRT, right?
Could be. It could be RT or CTRT. And say in broader aspect, when you are counseling these patients, when you discuss about the trials or so, orator, whatever is being cited repeatedly, what is the percentage of patients they land up with trimodality therapy in surgery arm? Can you tell us that?
Yes, ma'am. Actually, around
So to put it,
70%.
Akshat, I'm not differing with you. I'm with you, but I'm also rephrasing that what is he needs to mention to the patient
Yeah,
that
definitely.
what is the
Definitely.
percentage of the patient that will
Around-
land up with trimodality therapy.
Yes, ma'am. Around 70% of the patients will land up in trimodality treatment, ma'am.
Correct. So that is a very important part when you are counseling your patient for surgical arm vis-a-vis CTRT.
Okay, ma'am. Yes,
Now,
ma'am.
if you are your patient chooses CTRT, what
Yes,
will
ma'am.
be your discussion around this big neck nodal mass that's there or the primary that is there? If the patient asks that, okay, fine, I'll take CTRT, but what happens if my tonsil mass does not go away? It still remains. And what happens if my neck mass also remains? So how will you counsel that bit to the patient?
Yes, ma'am. So I'll tell the patient that post CTRT treatment, if the patient has any residual tumor, like if there's a residual neck mass, then we can actually go ahead with the salvage neck dissection in this patient, ma'am.
How will you establish that residual neck mass's status? What kind of imaging will you do?
Ma'am, ideally we should be doing a PET CT scan, ma'am, and so we'll see the response to the treatment, and also, ma'am, we can see based on the RECIST criteria whether the tumor has resolved or not.
So suppose the patient comes to you post CTRT and the PET scan you have done,
Yes, ma'am.
and there is no, or it may be just like diffuse uptake in the PET CT, but you can see that there is around 1.2 centimeter, 1.5 centimeter neck node still remaining.
Yes, ma'am.
So what will you like to do for that?
Ma'am, I didn't hear you. How much centimeter you said? Sorry.
Say you can say it was to begin with 3 centimeters. Say it has reduced by half, 1.5 centimeter remaining. Diffuse uptake or almost no uptake in FDG.
Yes, ma'am. So, ma'am, there's one Hopkins criteria for like PET scan evaluation we see for response. So in that, ma'am, like if there is diffuse uptake at the primary or on the nodes, which is like more than the uptake is more than the IGV or the liver. So we say that it is 3. The score is 3, and it's likely post-RT inflammation. So in that case, we can observe, ma'am.
Okay.
Yes, ma'am.
Would you like to go ahead with FNA for a
Yes,
1.5 cent? Are you aware of pet neck study?
yes, ma'am. Pet neck trial.
What is
So,
the
ma'am,
criteria for addressing the neck?
I think, ma'am, around like a 1 centimeter, 1 centimeter node in the lateral cervical region and around 8 mm in the central compartment, ma'am, I think.
But you are talking about observing 1.5 centimeter node. So would you want to observe or you want to do something further?
Ma'am, 1.5 centimeter node will do a FNAC, ma'am. FNAC.
Okay.
And say your patient is HPV positive. The node is necrotic now.
HP positive is necrotic node. Then that's what, ma'am. Post we can do an FNAC and like we can counsel the patient for a salvage.
Prakash,
Say,
previously you mentioned that as per Hopkins criteria, if uptake is more than liver, it is inflammatory. It's not so. If it's more than liver IgV and
It's a
if it's
diffuse uptake, sir. Sorry, sir. Diffuse
yeah,
uptake.
diffuse word is there. Secondly, if it is more, then we are suspecting that something is going on, right?
Yes,
So
sir.
focal and more than the two is suggestive of disease being there.
Disease 4
So
and 5. Yes, sir.
you are looking at two aspects. Number one, functionally, whether there is any uptake being seen. Secondly, morphologically, whether the node is still there, necrotic node is there, or the size is more. All right.
Yes, sir.
So
Yes, sir.
all these factors are being considered before you are saying that patient is disease free or not.
Yes, sir. Got it.
I would want to go back a little bit. Say you're talking about surgery for this patient. You take this patient for a transoral robotic resection. What margins are you looking for in this patient?
So ideally, we should try to achieve more than 5 mm margins. So we take ideally we take a 1 centimeter margin, sir. But
You will get 1 centimeter margin in tonsil.
lateral margin will be difficult to achieve, sir. So like they say, like more than 5 mm is like 5 mm should be the like adequate margin that we can take.
What would you look in imaging or clinically before you decide that, okay, I can take this patient for TORS? Say this patient was N0, not having a bulky neck node like this guy's. So it was just a tonsillar lesion, which you had mentioned.
Yes, sir. So we'll look for the extent of the tumor, sir. Like for instance, this looks like a lateralized tumor.
Yeah,
So
what
it's,
extent are you talking about?
yes, sir. So
And what will
like,
you look in imaging?
right, sir. So like if it's going beyond the superior constrictor, if it's involving the parapharyngeal space, so that will be like that will be a contraindication for surgery. And even if it's like going more than 1 centimeter, if it's involving the soft palate or the base of tongue more than 1 centimeter, so I won't consider it lateralized, and that won't be a candidacy for TORS. And also, if it is extending into the posterior pharyngeal wall and into the prevertebral space, so that will be a contraindication. And other than this is what
1 centimeter extension to base of tongue or even soft palate is not a contraindication. All right.
okay, sir.
It depends whether it's coming close to midline, whether you want to do it, that's a different thing. But then you can still resect these patients. Parapharyngeal, just a focal bulge into it is again not a contraindication. You need to see whether you're getting planes with carotid, you're having adequate soft tissue out there so that you get a decent margin out there.
Yes,
All
sir.
right.
Yes, sir.
Would
So
you
the
be
main
sending such a specimen for frozen section?
so
Would you be sending such a specimen for frozen section?
no, so ideally we send the entire specimen in toto. So like in TOS, we consider doing an en bloc resection and sending the entire specimen for HP examination.
No, would you be doing frozen section? I'm asking.
Frozen in TOS, so I'm not aware of that.
So TORS is just like any other surgical modality. You are supposed to check even intraoperatively. How will you revise the margins otherwise?
Okay, sir.
All right. So frozen should definitely be resorted to. You may be missing out on something. So you should be aware, because that's when you can actually revise margins if feasible. All right.
Okay, sir. Okay, sir.
Dr. Prakash, what is the margins that has been taken in different studies, like you said, ECOG 3311, and what are the margin they have taken it as considered to be negative, not to add any adjuvant?
Yes, ma'am. In ECOG 3311, ma'am, they considered 3 mm,
Yes.
3 mm margin, and in pathos, ma'am, pathos they considered 5 mm margin, ma'am, in the pathos trial, and in ECOG E331 it was 3 mm, ma'am.
So you can give a range of margin. Dr. Akshat asked you what is the margin. You can give a range 2 to 5 millimeter.
Okay, ma'am, 2 to 5 millimeter. Got it, ma'am.
Prakash, I just want to ask you a simple question. How far does the carotid lie from the base of tonsil?
Ma'am,
Normally?
yes, ma'am. 1.5 to 1.7 centimeter, ma'am. Like it's like lateral to the bed of the tonsil, ma'am.
Correct. This is say like a 1 centimeter tumor, you said your case. Of
Yes,
course,
ma'am.
must be having some amount of infiltration inside. How comfortably will you get a 1 centimeter margin around that? Practically?
Yes, it will be difficult to get a 1 centimeter laterally towards the bed. 1 centimeter margin is not like it's difficult to get. So that's so, ma'am. Like as you said, ma'am, 2 to 5 mm should be the ideal margin, ma'am. So ideally we take the tonsil with the superior constrictor muscle. So that is what we consider as the bed of the tumor.
And how good is your palpation? Because see, in robotic surgery, a good lot you have to lose on the tactile sensation, right? So
Yes,
how
ma'am.
good is your palpation to differentiate whether you have taken a 2 millimeter margin vis-a-vis a 5 millimeter margin or a 7 millimeter margin? You suppose get up from the console, go to the bedside, palpate the base. How convinced you are that you have taken a 5 mm vis-a-vis 7 mm? These are practical issues I'm asking you, nothing to do with theory.
All right, ma'am. So we can the specimen, ma'am. We can just palpate the specimen. Oh no, what we do is like in TOS we actually cut the tumor, ma'am, in the center after we dissect it, and we see the distance from the bed, ma'am.
On table, you mean to say, like grossing?
After removing it, after removing the table, the surgeon himself can like dissect the tumor in the center and just see the depth, ma'am.
It's better if you don't do it yourself, you go to a pathologist and let them do that part.
Okay, sir.
Dr. Prakash, just to cover a bit about neoadjuvant chemotherapy, is there any role of neoadjuvant chemotherapy in the oropharyngeal cancers? And are you aware of any studies which say yes, we have to go ahead or we should not? And suppose you are planning to treat the patient with a non-surgical treatment modality, would you add neoadjuvant chemotherapy or will go directly to concurrent chemoradiation?
Yes, ma'am. I'm not read in detail, but I am aware of few studies which investigated the induction chemotherapy, like the Optima study, and also there was one UCLA study, ma'am, where they investigated with.
So those are for those patients you are considering for TORS after NSCT, not for, I am talking about non-surgical section.
I'm not aware of that, ma'am. I'll read about it. There was one study, ma'am, E1308.
Are you aware of tax studies, tax 323, 324,
Yes,
decide, paradigm? So these are the studies you should actually remember in your exam. They might ask like whether to consider for neoadjuvant chemotherapy or not, or to just because sometimes the patient comes with a big nodal disease and you consider, okay, let's send for neoadjuvant chemotherapy. So you should know you can send, but you should know whether there is any evidence for that or not.
Okay, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
And we discussed a little more about HPV positive, though our population is mostly HPV negative. So what do you think, HPV negative cancer? So we discussed about TORS, we discussed about chemoradiation. For HPV negative, what would be your preferred treatment option? Will it be surgery? Will it be chemoradiation? Or you want to give surgery followed by adjuvant chemoradiation? What would be your treatment option based on the stage?
In HPV negative tumor, ma'am, if it is only a T1, T2, N0, in those cases, I'll consider definitive RT versus surgery followed by adjuvant. But if it's like N1, T1, T2, N1, in N1 case, I'll prefer ma'am CT-RT in such patients, and even in advanced cancers, CT-RT should be preferred over surgical line of management.
So are you talking based on any evidence, or you are just talking, okay, it is HPV negative, let us do surgery? Is there any evidence which categorizes T stage, N stage, and what is where to go ahead with surgery, where to go ahead with chemoradiation? Because we always discuss about HPV positive, so that's why I was asking this question.
Yes, ma'am. There was this McKinsey study, ma'am, and also Gortec 9401. They said that there is the survival is significantly better when ma'am CT-RT, ma'am.
McKinsey that compares different chemotherapy regimens, whether it is neoadjuvant, whether it is concurrent or adjuvant. It doesn't have to do with anything regarding to what is the treatment option.
An option in this case.
So there is a large national cancer database study that is the probably only study which have categorized the patients T1, T2, N0, N1 versus T1, T2, N2, N3 versus T3, T4, N1, N2, N0, N1. So in those cases, basically when the tumor size is small, the preferred option could be a surgery followed by adjuvant. But when it is a T3, T4 tumor, chemoradiation should be considered. So that is what it has been said. And for HPV negative, do you think is there anything we should think about treatment escalation, and any work has been done or ongoing on treatment escalation? Not de-escalation. It is, I'm talking about escalation in HPV negative.
Yes, ma'am. In HPV negative, treatment escalation should be done actually because, but ma'am, I'm not aware of any work.
Okay. There is Dahanka study and compare study, which is HNCIG group. They are doing a compare study that you can see. So that is not only HPV positive, it includes HPV positive as well as negative. So basically, the reason for failure of this de-escalation studies is the selection, because they have also included the intermediate risk groups. So in the compare study, they are including this group as a high risk patients, and they have escalated the treatment. So we are awaiting the results. So this is just for your understanding.
Okay, ma'am, I got it.
Just carrying that forward, are you aware of any studies which have looked at hypoxia and impact of radiation on treatment de-escalation or escalation?
Yes, I read about it, but no, I don't remember exactly. I'm aware that it's included in de-escalation, hypoxia related, but I'm not read the study in details.
Dr. Prakash, I mentioned the name Dahanka.
So there they have looked into this aspect. That's what Madam mentioned.
Yes, I got it, sir. Dahanka study. I got it.
So, Dr. Prakash, just to say, since we are approaching almost the end of the discussion, for your patient of this 1 centimeter tonsil or 1 point something centimeter tonsillar mass, 3 centimeter neck mass, what would you actually like to advise this patient? What is your treatment main suggestion, or you will just leave it to the patient?
In our setting, ma'am, in Indian setting and in our institute, will prefer to give this patient the radiation option, concurrent chemo radiation option, ma'am, from this patient, ma'am.
Okay. And surgery you will reserve as a salvage?
Yes, ma'am. So because of if the neck node doesn't resolve, we can keep the surgical option as a salvage setting, ma'am.
We do not have time much, but I think we need to look little more on the salvage surgery setting. You were telling about doing an FNAC in those nodes, or how do you decide? P16 status does have a bearing to that, right? P16 positive neck nodes involute later. Do you know of that, or can you comment something on that?
Yes, ma'am. P16 positive patients
Simply
are more.
put, I'm asking, say like now you have said that you will advise the say like RT, CTRT route to the patient. Now, how you will establish a candidacy of salvage surgery? You have explained to what Akshat was asking, how you'll establish the candidacy of a primary surgery, like a robotic surgery. Now, how will you establish a candidacy of a salvage surgery? Suppose the patient has undergone radiation. When will you say, like, this neck node needs to be operated, this primary needs to be operated?
Yes, ma'am. After the CTRT is completed, if there is partial response, ma'am, to the chemoradiation protocol, if there is more than like 30%, if there is more than 30% decrease, or if there's a progressive disease, like ma'am, if there's more than 20% increase, so in those cases we'll consider for a salvage surgery in these patients, ma'am, because the node has not responded.
30% won't come at this part. All right, that's part of RECIST criteria. But then here, what are you looking at? That's simply what we are asking. What are you looking at to understand whether you need a salvage surgery?
We'll be seeing at the nodes, node status basically. If like if the node is still present, and if it is not resolved, like if it's more than 1 centimeter with a necrotic node, so we'll consider salvage surgery for these patients.
So irrespective of your FDG uptake or not, if there is a structural disease remaining, you will operate?
This will be complemented with the PET scan also. So we'll see the FDG uptake. As I mentioned about Hopkins criteria, we'll also see whether the how much is the uptake.
Like
And
Dr. Satakshi just mentioned, or rather she was asking you, that HP positive nodes may take longer to resolve. All right. Normally, we expect nodes to resolve after radiation, say within a time frame of 8 to 10 weeks or 12 weeks. That's why we are considering doing scan at that time. But HP positive ones may take even longer to resolve. All right.
Okay, sir.
So you need to be aware of this part.
Okay, sir.
I guess it's 7 o'clock. So should we wind up here, or what is your suggestion?
Yes, I mean,
I have no further questions to ask, so I think we can wind up. One or two take-home
I
points for
just-
everybody, if you can tell.
I just have something to add, actually, to ask. Just to complete the entire discussion, Dr. Prakash, suppose this
Yes, ma'am.
patient is a T1, T2, or suppose T2 tonsillar tumor, and you have decided to treat with radiotherapy. Is there any other option of treating rather than external beam radiotherapy that should be considered?
You can also consider like brachytherapy, ma'am, like in these patients.
Okay. It is so just to complete this, that for patients with lateralized tumors and very well defined like T1, T2 tumors, you can consider for external beam radiotherapy followed by brachytherapy boost. There is a publication from Tata Hospital by Dr. Ashwini Budrukar, which shows that helps in reducing the xerostomia, that also leads to an increase in the local control. So that is one of the options which you should consider. Like you can say this can be one of the options when T1, T2 tumors is being discussed.
All right, ma'am. Yes, ma'am. Got it.
I would like to ask all the examiners, how did Dr. Prakash perform, and any suggestions for him?
He did well, but then he needs to read a few more things like which we had discussed. So more contemporary evidence data set to review and be aware of.
Yes, sir. Okay, sir.
So feedback from mine is almost the same as Akshat. See, one thing we got blurred about. One is candidacy of surgery, candidacy of radiation. There is no clear winning arm for the case that you presented. So your data synthesis and understanding of the literature matters. Counseling of the patient and those aspects, practical aspect of it, I feel needs to be understood little more. meaning to say not only the evidence, the practical implications and application of it. It was a good presentation otherwise.
Dr. Prakash, you had a good presentation. I agree with both the other examiner. So you did well, but when you are talking about like surgery, chemoradiation or radiation, you should be talking about based on which factors. Like before you say anything, you should have to say that these are the patient-related factors, these are the tumor-related factors. These factors I would consider and best in these scenarios. Or you can ask like what scenarios, based on these scenarios, you can take a call, because there is nothing which is better, which is worse.
Yes, ma'am.
Otherwise, it is good. Yeah.
Okay, ma'am.
And
Thank you.
also,
Thank you,
you need to
everyone.
read more about literature also. Yeah.
Yes, ma'am. Thank you.
Thank you, everyone. It was a good discussion. So we'll meet again next time on October 25th with the new topic and a new presenter with new set of examiners. Thank you, everyone.
Thank you.
Thank you, ma'am.
Thank you.